Well, welcome everyone. We're going to be introducing facilitating progress in early detection and intervention in lung cancer, proactive strategies to improve lung cancer screening for high-risk individuals in the VA healthcare setting. And today I am fortunate enough to have Dr. Nicole Tanner with me. Dr. Tanner is professor of medicine and co-director of the lung cancer screening program at the Hollings Cancer Center in the Division of Pulmonary and Critical Care Medicine. But more importantly, she is a veterans physician. She works at the VA Medical Center at the Ralph H. Johnson VA in Charleston. Dr. Tanner is nationally and internationally known for working in lung cancer screening, having published more than 100 peer-reviewed manuscripts, book chapters, and other works in lung cancer screening. Almost all of her career is devoted to that. And welcome, Dr. Tanner, and thank you for joining us on behalf of veterans everywhere.
Thank you so much, Dr. Silvestri. It's really a pleasure to be here today to have the opportunity to share with the audience all of the great things that are being done around early detection.
I would like to thank PeerView and the National Association of Veterans Research and Education Foundations for providing this session, and also Merck for providing the educational grant for this symposium. As a reminder, I'd like you to look out for additional polling during the presentation. Submit your questions and we will answer them during a question and answer session forthcoming. Visit us at peerview.com VA/VA lung screen. View the slides and practice aids now and download them after the event. Need more information? Send an email to live@peerview.com and join the conversation on X @peerview. So what are our goals for today? We want to augment your knowledge of the importance of lung cancer screening, the current gaps and opportunities for improvement, but particularly focus on VA settings. And we really want to equip you with strategies for implementing high-quality lung cancer screening in the VA and beyond. And so educating your patients and staff about the importance of and access to clinical trials is another important aspect of this work, and increasing the diversity in clinical trial enrollment is crucial. And providers need to discuss with and offer clinical trials to all patients who they encounter at the VA. And greater participation equals greater patient access to new therapies. And of course, a lack of participation delays us in developing new therapies and causes higher costs. The National Association for Veterans of Research and Education Foundations, why do they do research at the VA? It's the largest integrated healthcare system in the country. It has a single electronic medical record with more than 9 million patients with racial diversity. And it brings together industry, VA medical centers, and VA affiliation research nonprofits to increase the number of high-quality industry-sponsored clinical trials, to speed up the launch and execution of clinical trials, and to improve recruiting, enrollment, and retention of study participants. So, lung cancer screening, really want to talk about the current status of screening, the randomized trial and evidence that's come into policy. And you can see on the upper right-hand portion of your screen the number of patients that died since the randomized trial was developed in the chest X-ray arm, and then in the low-dose screening arm, where there was a 20% reduction in lung cancer-specific mortality. That led to a lot of policy, and you can see all the policy-making boards that participated in lung cancer screening and developing guidelines for lung cancer screening. And it received a Grade B recommendation by the United States Preventive Services Task Force for all those adults aged 50 to 80 with a 20-pack year history of smoking who currently smoke or quit smoking within the last 15 years. And so I'd like to consider a case, and we're going to bring this case throughout the program. Mr. Smith is a 70-year-old man established in care with the VA administration and presents for his first primary care visit. He has a past medical history of COPD, coronary artery disease with stents placed in 2022, hyperlipidemia. He's had a cholecystectomy and a family history of a brother who died of lung cancer. His social history is that he's a retired contractor for a construction company. He was in the Navy for 9 years before leaving the service. While in the Navy, he worked in the boiler room and was exposed to asbestos. He currently smokes an average of about a pack a day for 50 years, and he drinks alcohol on occasion. So the first thing we'd ask is this veteran eligible for lung cancer screening? And the answer is most definitely yes. And there have been two updates. The initial update to the United States Preventive Services Task Force that found screening efficacious, and that was in 2013. At that time, they recommended it for people age 55 to 80 with more than a 30-pack year history of smoking. If they had quit within the last 15 years. And at that time, there were about 8 million eligible Americans. The Nelson trial, which was a randomized trial in Europe, included younger patients with less of a smoking history. But if they had to quit within 10 years. Because of the results of the Nelson trial, the USPSTF expanded their eligibility down to age 50 and down to 20-pack year history from a 30-pack year history. They left the previous quit to 15 years, and that added about 7 million more people. So now about 15 million Americans are eligible for lung cancer screening. We were lucky enough to look at the first million persons screened for lung cancer in the United States. And in 2022, we published a paper looking at a few things. But one was, what was the eligibility? Did people meet that eligibility criteria at that time of 55 to 80? And actually, what great news was, of those over a million patients, about a million, or 91%, met the 2013 criteria. Among those who didn't meet criteria, 50% were people who had less than a 30-pack year history of smoking or had quit more than 15 years ago, and so on and so forth. Actually, if we had applied the 50 and 20 pack year history that's now eligible for screening. An additional 40,000 patients, or 38% of the people who didn't meet enrollment, would meet now eligibility criteria. So really good news is most people that get screened for lung cancer in the United States meet the eligibility criteria. And what we also found in that same paper is when we compared those people who were eligible to those observed from the National Health Interview Survey, we found a few things. One was that more women were screened, about 15% more than we expected. More people who were a bit older than 65, were screened, about 30% more than we expected. And more current smokers, about 17% more than expected. Patients tend to be more educated, 23% more had a college degree, and patients who were Hispanic were less likely than expected to be screened. We had reasons for all of those things, but more women, mostly because women have been engaged in preventive services between mammography and cervical cancer screening. Older patients in the United States are more likely to have health insurance coverage by way of Medicare. And those who are educated seem to get more information about screening. The current smoker part of this surprised us, and one of the things that I think Dr. Tanner will point out is that it's not easy in our medical record to identify those who formerly smoked, and it's not top of mind of either a patient or a provider that a patient quit smoking, for example, 10 years ago, but still might be eligible for screening. And if we look at the graphs, again, the big three were more women, so we have to focus our efforts on men, and this is particularly true for the VA. More elderly patients. This might not be a problem with the VA, where we have more of a health insurance policy under the Veterans Affairs Act, but more current smokers, and identifying those former smokers will be important. And so one of the questions we also asked was, do patients return for annual screening? And actually, we were quite disappointed. Only 22% returned if they had a negative screen to begin with, return the following year. This is really, really important. And of those people, even if you extend it out to 24 months or 2 years, only about a third returned. And then even if you said, look, if they came any time after their initial screen that was negative, only 40% returned. And when we did logistic regression, African-American patients and Hispanics were less likely to return. Those a little bit less educated were less likely to return. Those who didn't have health insurance was the most difficult to get back, at 55% did not come back. Even though we screened more current smokers, they were less likely to come back. And if you lived in the South, you were also less likely to come back. If you did have a positive screen, you were 3.6 times more likely to come back. And so people who had, suspicious findings were, of course, more likely to come back. Why is coming back important? Well, this is from the Nelson trial. And in one part of their trial, they went out from doing yearly scans to doing a scan every 2.5 years. And what they found between their round 2 and round 4 screens were that stage 1 cases that were diagnosed were a lot less likely. Stage 4 cases, 3 times more likely to find patients with stage 4 disease. Adenocarcinomas, which in this study were more likely to be cured, were less likely, and squamous cells were far more common. And interval cancers were far more common. So we know that coming back yearly makes a difference in terms of finding those cancers early, and so adherence is a huge problem. And then if you look at some of the important research that's been done, it's actually been done by Dr. Tanner in her lab, but repeat scan within 15 months, adherence in the VA at between 2013 and 2015 was 82% at year 1, but dropped to 65% in year 2. And that was data published by Dr. Tanner. In a meta-analysis, one of the things they found was about a 55% adherence, but the definition was a little looser. Up to 36 months, they defined adherence. If they had been strict, it would have been much, much lower. And that was that eerily matched the Million Screens paper I previously spoke to you about. Centralized programs, meaning that you have resources centrally located, Dr. Tanner's going to get into that in a bit, did much better in terms of adherence than decentralized programs where a primary care provider could order the test on their own. There was no infrastructure, no nurse practitioner, advanced practice provider to follow those patients up. They had much lower adherence. And one really important paper was if you dropped adherence down to 46%, the mortality benefit was cut in half. So we believe that adherence is super important in terms of being able to get everything you can out of a screening program. So what's the status of lung cancer screening in the VA? I'd like to turn the program over to Dr. Tanner, who's done much of the work, both at our local VA, the Ralph H. Johnson VA in Charleston, but also nationally.
And so thanks for that background, Gerard. I think it was really helpful to kind of set the stage. And so I've been tasked with talking about the status of lung cancer screening in the VA. And I have to say I'm really proud of what the VA has been able to accomplish over the years. We know that lung cancer is the leading cause of cancer death for our veterans. And we estimate that anywhere from 1.5 to 2.5 million veterans could be eligible for screening that receive their care at the VA. Historically, VA diagnoses and treats about 8,000 veterans with lung cancer annually, and approximately 5,000 veterans will die each year from lung cancer. And this is a quote that was used with permission from one of our U.S. Navy veterans who wanted to thank the VA healthcare system because of a lung cancer screening exam that he had that found a cancer in the right upper lobe that he was able to be cured from. And so that's the whole point here, is that we want to make lung cancer survivors through our screening efforts. And so what has the VA done? This is a great timeline that kind of illustrates what has been going on in the VA healthcare system since 2013. Even before, right at where the task force criteria came out, even before there was a U.S. Preventative Services Task Force recommendation, people were working in the background nationally trying to figure out how we would be able to implement lung screening after the findings from the NLST trial. And I've circled on this timeline some of the really big pieces that have contributed to what we've been able to accomplish. One was the VA Lung Cancer Screening Demonstration Project, which was done at 8 sites, including our own, to look at what type of resources would be needed to scale up lung screening. Following the demonstration project, there was a memo that was released in 2016 that said if a veteran wanted to be screened, we should offer it. And then I think one of the seminal changes happened at the end of 2019 with the National Oncology Lung Precision Oncology Program, which really sought to increase access to lung cancer screening across the VA healthcare network, as well as equally as important, molecular testing to veterans who are diagnosed with lung cancer to ensure that they get the right treatment for their cancers. Then at the end of 2020, the National Center for Lung Cancer Screening was formed, and I'll talk a little bit about that. And most recently, there was an updated memo that was released that really highlighted that lung cancer screening is now a mandatory offering to all veterans who are potentially eligible. And so that's a lot, and I'll talk about these first two pieces here quickly. And so what we've learned, Dr. Silvestri pointed out, when you look at a centralized screening program versus a decentralized program, there's higher quality when you can centralize many of the components. And because you have a group of people that are really focused on eligibility, you can confirm eligibility and then find time to conduct shared decision making. This was the first screened for cancer where the task force, as well as the Centers for Medicare and Medicaid, said, there's enough risk and benefit involved that we want people to know straight up what they could be looking at so that we don't cause distress. Let people who are being screened know that there's a chance that there might be a nodule, but not all nodules are cancer. And so in the confines of a busy primary care practice, it's really difficult to conduct shared decision making when you're dealing with chronic illness. And so a centralized program has someone that's appointed to do that. At the same time, many of the nurses and advanced practice providers are also talking to people who are currently smoking and initiating tobacco treatment. This group is responsible for communicating the results back to the patient and the referring provider. And importantly, managing screen-detected nodules. Many of the facilities have nodule boards where they review images of anybody with a screen-detected nodule. They also have multidisciplinary thoracic tumor boards to discuss about multimodality treatments. And then the really important thing to a centralized lung screening program is to have a way to track patients. We spend a lot of time talking about adherence and the importance of coming back for follow-up. And so having a centralized program kind of ensures all of these high-quality components. And so the needs really are at the system level. We need a way to identify patients and manage and track them. At the provider level, it's really important to educate on who is eligible, how to use the system prompts, how to collect a proper tobacco history. And then at the patient level, doing shared decision making so that they understand and make a decision about screening that's in line with their values and beliefs, communicating the results to the patient and the provider, and again, adherence. And so we really had all of these things that we knew from the demonstration project. And at the time, the first memo was put out there, but we didn't really have all of the resources to upscale. And that's where the Lung Precision Oncology program came in. And so the LPOP is really, I would like to say, a system of excellence. And the goal was to create a national network on precision oncology in both lung cancer research and clinical research that includes lung cancer screening, smoking cessation, genomic testing, and improved treatment modalities. The objectives were to provide opportunities to increase veteran access to precision oncology comprehensive research and care, including screening, in a way that would benefit VA clinical care operations, the research enterprise, and most importantly, our veteran population. It's a nationwide network of a hub and spoke design. If you're VA friendly, as I hope many of you on this call are, you know that we have VISNs, which are integrated networks, and each VISN has at least one hub and many spokes. And at this point, we have 24 hubs and 87 spokes. And what that allows us to do is to expand best practices to smaller facilities that maybe don't have all of the specialty care. For example, you might be at a smaller, more rural VA facility, but you're conducting lung screening, and to have access to pulmonologists and oncologists who specialize in diagnostics and staging and surgeons through virtual meeting platforms is a really benefit and ensures that our veterans are getting the same type of high quality multidisciplinary care no matter where they live. And so there were some measures that were put together for LPOP to show that we were being successful and providing high quality. And so there are measures of access as it relates to lung cancer screening. So we want to increase the number of veterans who are actually assessed, and that's to know what their tobacco history was and smoking history. To increase the number of veterans who are offered lung cancer screening. You'll notice I say offered because it is a choice. And increasing the numbers of those who are offered divided by the number of veterans assessed. So these are the equations that we do. There's also been a huge effort to ensure that the quality of lung cancer screening is good with templated reporting from the radiologists, with multidisciplinary discussions, and really importantly, to get our veterans to come back for follow-up even if there was no finding. As it relates to lung cancer treatment, I mentioned this before, molecular testing is really important in pretty much all stages of lung cancer care. And so the VA has enabled all of our veterans who are newly diagnosed with lung cancer at the appropriate stages to have access to molecular testing without any charge. And this really impacts care. An increase in clinical pathway use, which is guideline concordant lung cancer treatment that helps providers in the more remote areas ensure that they are following guideline recommendations for lung cancer treatment. And so really, we like to call this exercise really utilizing and harnessing the VA as a learning healthcare system, where research findings feedback in real time to clinical care, and clinical practice and gaps in what's happening with boots on the ground inform what type of research focuses need to happen. And it's a nice circular relationship and collaboration. And so at the start of LPOP, we knew that there were some resources that were going to be needed. And from the demonstration project, we knew that there was going to be some coordination challenges. And so in many instances, there was a lack of staff in the pulmonary medicine office. We didn't have a structured approach at the enterprise level to screen lung cancer. in the VA, and an inability to track screening procedures across sites. And so because of this, there was no way to benchmark screening performance against any standards. And really, it was difficult to ensure equitable access to lung cancer screening. And so what was done at the system level was to determine a way to figure out who is eligible. And so if anybody works in the electronic medical record in the VA, there are clinical reminders, and these collect data points that generate something called health factors that let us identify who's eligible. So at the boots on the ground level, when a veteran comes in for a clinic visit, these reminders, which are standardized across the VA enterprise, collect a tobacco pack year history. And then this populates something called the lung cancer screening platform, which allows patients to be managed. It's a dashboard that moves patients from point A to point B and lets the lung cancer screening coordinators know who is eligible, who has accepted, who has declined, who's due for their follow-up, et cetera. At the provider level, there's been a number of resources put into dedicated training of new lung cancer screening coordinators, with regional and national coordinator advisors who we consider our super users and are a good point of contact for spreading best practices. There's also office hours from the National Center for Lung Cancer Screening. There's education of primary care providers and RNs at the local sites by the lung cancer screening programs. For the patients, a number of shared decision-making decision aids have been developed, and numerous iterations. Tobacco treatment has been embedded, and educational material following the results of the pulmonary nodules are available for distribution to patients who have an abnormal finding. And so I'll turn this back over to Dr. Silvestri to look at uptake in the United States.
Well, thank you. So one of the things we do know is that uptake in the United States has been really poor, probably between 16 and 20%, and that's optimistic. It was as low as 6%. And so when we think about that compared to colorectal and breast cancer screening, where we see 70 or so percent of women engaging in breast cancer screening and 60 to 70% of women and men engaging in colorectal screening, we have a long way to go. And as I mentioned before, the electronic medical record is poor at identifying eligibility by smoking status. The population in some ways has less access to health care because people who smoke tend to have to be less likely to have an ability to have access to medicine because they're either uninsured or underinsured, less educated, et cetera. And so we do have some barriers and challenges. And the primary care provider community has a lot on their plate, and they haven't embraced screening for lung cancer. And for the other two screening tests, major screening tests, it's just about age and gender. But among this group of lung cancer screening patients, you have to also calculate their pack year history and if they quit, when they quit. And so it makes it a little bit more difficult for a PCP to get patients engaged in lung cancer screening. And so, I'm going to turn it back to Dr. Tanner.
Thanks for that. Yeah. So uptake outside of VA and even within VA, I think at one point the lower estimates were about 20% in the VA that had undergone screening prior to all of these programs that I've discussed. But I did comment on the National Center for Lung Cancer Screening, which has a wonderful team led by Dr. Chris Latora out of the Portland VA Medical Center, have really tried to increase uptake that's fair and equitable across the VA enterprise. And so the mission for the National Center for Lung Cancer Screening is really to support a systematic and integrated access to high quality lung cancer screening processes for veterans, with the main goal of reducing lung cancer related mortality and morbidity by leveraging a learning healthcare system to increase access to evidence-based lung cancer screening through a collaborative and interdisciplinary network. So too, the National Center has partnered with other groups to integrate new treatments and promote lung cancer screening nationwide. For example, the National Tobacco and Health Program Office has a pilot that's looking at integrating tobacco treatment into lung cancer screening. The VA National Center for Homelessness also has been working with the National Center to develop lung cancer screening in a VHA homelessness toolkit for sites to use for veteran care and outreach. And lastly, there's an updated memo that I mentioned that now says that lung cancer screening is a mandatory service for our veterans. And so we're really putting a lot of resources behind access to lung cancer screening. And this is the directive that was put out in November of last year. And to achieve high quality screening, every VA medical center is to designate a physician lung cancer screening director and lung cancer screening coordinator to manage the program, have an oversight board, to use this platform that I discussed that helps in patient management, as well as the national clinical reminders that help identify and track veterans who are offered and enrolled in lung cancer screening. It's a lot of work, but there are a lot of tools and resources that are readily available through a large SharePoint. And there are office hours, and any new program that starts up really has a community of VAs that have done this before that are there to support and walk them through. In our own visit in the Southeast, we've been able to stand up lung screening in now 6 of the 7 main facilities through working together. And this is that hub and spoke model that I kind of talked about, where maybe a larger facility acts as the hub and assists in keeping our veterans screened and assists other smaller sites. And so a lot of these quality elements of multidisciplinary review can really be achieved in the era of technology with all of these platforms like Teams to talk about patients. Also looking at processes to offer smoking treatment interventions, etc. And so how is the VA doing? These blue blobs indicate the lung cancer screening sites and number of active patients in lung cancer screening. And so you can see this is data as of April of this year that we're having an increasing number of veterans that are being screened and an increasing number of sites that are offering screening. And so this is an update from the National Lung Cancer Center. We keep an active dashboard, and it's really a great thing to report on implementation of the 139 VA facilities. Currently 120 or 86 have an approved what's called clinical restructuring requests, meaning they're approved to move forward with lung cancer screening and are offering screening. If you look at access on the far right, you can see that over 2 million veterans have actually had their tobacco pack year history recorded, which is, were eligible. And of that, 1 million or 1.3 million have had those tobacco pack year histories recorded. A little over 400,000 are actually eligible for screening. And there were about half that had some exclusions. But then when you look at the number of patients without exclusions, 87% accepted lung screening. And of that, approximately 57% or 167,000 patients who receive care within VA have had a low-dose CT screening within 1 year after accepting, which I think is really quite remarkable. And we do talk about the quality and the metrics. And so if you look to the left there, the lung cancer screening adherence is really what we've been driving home. And if you remember, the first million screened in the US, adherence at 1 year was 22%. If you took it out to 18 months, it was a third. If you look here at the sites that are currently using that management platform that I was talking about in the blue bars, optimal adherence is at the 15-month mark, which was what was used in the National Lung Screening Trial. You can see adherence when you use the platform is 72%, which is why there's a push for all sites to adopt the platform, because it really is a great tool to help in patient management. And if you kick it out to acceptable, which is at the 18-month mark, 87% of our veterans are returning. So I think that adherence is really remarkable if you look at other large healthcare systems, and something that this coordinated effort that's been highly resourced is really a testament to what we're doing, because it's not the first scan, it's certainly the second scan where we find the next cancer and can save lives. This is another snapshot of the data that comes from the dashboard, and you can see proportionally the numbers of veterans who have accepted by race and ethnicity. You can see across all race and ethnicities, there's been a high acceptance rate. If you look at residential locations of those offered in these areas, there's been a high acceptance rate. so too by male female about the same. The CAN score is a VA specific marker of competing causes of death or comorbidities. The cutoff we think about is 60, as 60 and less. The lower the CAN score, the healthier the patient. And you can see across CAN scores, we are screening quite a few people, and I think that that's an area for future research, is to look at how comorbidities impact this. But you do see in the lower CAN score offerings, many of those veterans are accepting, and a little less in the higher CAN scores. And then if you look at housing status, regardless of where veterans live, there is a fairly high acceptance rate for lung cancer screening. And this is just another way to break down that pie. If you look at the race of veterans who have accepted lung cancer screening, as well as rurality, there's been a lesser group in the highly rural areas, as well as rural areas, that have accepted lung cancer screening in comparison to those in the urban areas. And this is another area of active study and active programming to try to find ways to reach our rural veterans. Dr. Silvestri, back to you.
Yeah, great. Thank you very much. I do want to take a moment and tell the folks listening to this talk that it's an incredible feat that the uptake among the veteran population has been 57% accepting and then getting a screen, as opposed to 16 to 20% of eligible Americans. And then also the adherence of 75 or 80%. We just don't see that, and seeing that occur in this very centralized, organized program is really fantastic. I'm going to present just a few slides on why. So why are we really doing this? And so this slide is a comparison of the National Lung Screening Trial and the Nelson Trial in Europe, which included 18,000 patients. NLST was 53,000 patients. And if you look first at the green and lighter blue bars, what you see is most patients present with advanced disease. Look at the Nelson trial, almost 50% had stage 4 metastatic lung cancer. In the NLST, 36%. And then stage 3 disease, pretty darn high, right? But if you looked at the group, those are the control groups. They didn't get a CT scan. But if you look at the active or intervention arm of a CT scan, which is in the dark blue and in the orange or tan bars, what you see is more than half. And those are stage 1 and 2. So much bigger shift towards early stage disease. We know that early stage disease, for stage 1 lung cancer, the cure rate is in 70% or above. For stage 2, 50, 60%. But when you get out to stage 4, you're talking in the 10 to 20% range of people who survive. And so the whole reason for this whole talk is to get those patients who are eligible for lung cancer screening to be screened and to find these early stage resectable lung cancers that have excellent outcomes. And now is there a stage shift in those screened for lung cancer. And so this is data from CHEST on those first 1 million patients screened for lung cancer in comparison to the National Lung Screening Trial, which is in the tan bars, and the dark blue bar is the first 1 million screens. And it's really, really impressive that 5% or so were in that early stage disease, which mirrored what we found in the National Lung Screening Trial, actually even slightly better. So the ability to move that from findings of a clinical trial, well-curated clinical trial, into the community is that we do see that same type of stage shift in our population in the United States and in the veteran population as well. And so again, getting back to Mr. Smith currently smokes 1 pack of cigarettes per day. He's done so for 50 years. And he had his first cigarette within waking of 15 minutes. And this timing of when someone has a cigarette, it's called time to first cigarette. And what we know is if you're having a cigarette within 15 minutes, you're highly addictive. If you smoke for 50 years, you're highly addictive. It's a daily habit. And he's attempted to quit twice by going, quote, cold turkey, which is, by the way, is the most common way people quit, except it's the least likely to be efficacious. And he both times without the assistance of a healthcare professional. And in both times, he failed within 6 weeks. Is what we find as a pulmonologist in our clinical practice. They can make it out to 6 weeks, but that nicotine addiction is so terribly difficult to kick. And so we believe that incorporating smoking cessation into a screening visit is important and potentially is a teachable moment. So this patient highly addicted, and they'll probably require both counseling and pharmacotherapy to increase their chances of abstinence. And so with that, I'll turn it back over to Dr. Tanner, who will talk about what's going on at the VA for that.
Right, just to kind of continue what you were talking about there as it relates to smoking, we know that an estimated 48% of U.S. adults eligible for lung screening actually currently smoke. And 58% of veterans who receive lung screening in the VA, at least between 2014 and 2018, currently smoked cigarettes. And 12% of those overall enrolled in VHA report currently smoking. And so 1 out of 2 people that we're offering screening to will be someone who's actively smoking cigarettes. And so what we've shown from our work looking retrospectively at the National Lung Screening Trial is that if you stop smoking and you undergo screening, your mortality reduction is even greater than that of the 20% seen. And so once you've abstained from smoking, even without screening, I think the mark was 7 years, you reach that 20% mortality reduction. So not that we're saying that we shouldn't screen people, but if you can talk to veterans and use that as a speaking point, we can screen you every year, but you'll really be adding to the benefit, to the health benefit, by quitting smoking along with screening. Adding smoking cessation treatment to lung cancer screening should increase smoking cessation and prevent additional lung cancer, reduce deaths, and increase life expectancy. This is all things that we know of, and certainly it's very cost effective. And what we know from the VA literature is that about 18% of veterans in lung screening received any smoking cessation treatment back in 2014 to 2018. So this was an area that we sought to improve. And so it's no news to this audience, but the 2020 Surgeon General report talks about certain life events, including hospitalization, surgery, and lung cancer screening as a teachable moment. Now, is undergoing lung cancer screening when you're asymptomatic a teachable moment? I think some would argue no, but in a centralized program where you have a captive audience, it's certainly a start. And so I think this is another benefit to having a dedicated lung screening coordinator who's working with the veterans around lung screening, because they can establish rapport and start a conversation. And many of them are certified as tobacco treatment specialists, and it's a journey. It's not a one-time event. And so establishing that kind of discussion at the beginning. And so really, there's a lot of touch points when the scan is ordered at the time of screening, when the results are being followed up upon. And repeat outreach obviously can increase enrollment and treatment. And as Dr. Silvestri alluded to, this is a very difficult to treat patient population. They're less ready to quit, and they're very dependent. And so the VA has put a lot of resources behind pharmacotherapy, including varenicline, and counseling. And so to that end, there have been other studies that have been done called the SCALES trial, the Smoking Cessation at Lung Examination Collaborative, or SCALES, that have been done in a number of places. And I won't read all of these to you, but essentially these were studies that were funded to look at how to best integrate tobacco treatment within lung cancer screening. In the Georgetown treatment trial, they had a phone intervention, and they found that an intensive short-term telephone treatment was more effective than a few treatment sessions. In the Pluto study, they did 1-year tobacco treatment model, and this resulted in relatively high long-term quit rates. If you add in prescription medications for early non-responders, it really didn't impact abstinence. And the trend of higher abstinence rates were higher in those who had monthly follow-up calls compared to quarterly calls. So really, what a lot of this data tells us is that you need to have intensive interventions to be effective. The OASIS study showed that without providing additional resources, sites who chose to implement minimal, less intensive interventions and those that provided medication and counseling had higher abstinence rates. Providing resources and support for more intensive long-term interventions could improve abstinence outcomes. And so, anything is good, but more intensive is potentially better. And so there's actually an ongoing clinical demonstration project within VA to integrate smoking cessation into lung cancer screening. And this is the collaboration I alluded to before from the Tobacco Use Treatment Program with the Office of Mental Health and the National Center for Lung Screening, as well as National Oncology and LPOP. And so they are looking at a more pragmatic way to implement different ways to offer and deliver smoking cessation treatment as part of lung cancer screening. And obviously the goals are to increase evidence-based smoking cessation treatment, use of FDA-approved medications and behavioral counseling to any veterans undergoing or eligible for lung screening. So even if they say, no, I don't want to be screened, if they're currently smoking, we try to initiate conversations, see the veteran where he's at, and offer him or her treatment if they're willing. And really to try to identify effective clinical practice models to integrate evidence-based smoking cessation treatment into lung cancer screening. There are monthly community of practice calls where different sites will share what they're doing with the hope of disseminating best practices and giving other groups ideas. And kind of one size doesn't fit all. Not all resources are available at all VAs, but hopefully folks can take what they need and try to implement locally. And I think this has grown in a really great organic way. These are the sites you can see if you are at a VA, if you are part of these sites, but these are the active sites. It's a little bit old as of last year, but I believe these are the same sites that are up and running currently. So future steps, partnerships, I did mention the VA National Center on Homelessness with the toolkit, and some of the facilities that are participating, at least 50% have installed that platform. One thing I'll talk a little bit about is mobile lung cancer screening as a way to reach rural veterans. And then research really to harness VA as a learning healthcare network to contribute. And there is a prediction augmented screening initiative, which I'm fortunate enough to be a part of, which is a randomized trial at 28 sites to look at implementation of prediction tools that better identify and improve lung cancer screening uptake among veterans who could benefit the most, and evaluation and incorporation of biomarkers into prediction and eligibility. This is kind of the future of lung screening, and I'm proud to say that VA is really trying to take the lead. So mobile lung cancer screening is a potential solution for access. We talked about lung cancer as being a problem, but it is definitely higher in rural versus urban areas. And most of the community-based outpatient clinics that are affiliated with VAs don't have their own dedicated CT scanners. For example, in our VISN 7, we estimated that about 36% of veterans lived greater than 60 minutes away from their closest VA CT scanner. And while community care is there, meaning we use other non-VA vendors to do scans, it's not always an ideal option because it's difficult to get the scans back as well as the reports. And so we thought that mobile lung cancer screening could be a potential way to reduce travel time, improve VA continuity of care, provide veteran-centric care, and of course, improve adherence. And so just to speak to the pilot that we're doing in VISN 7, which includes Alabama, Georgia, and South Carolina, based on what we looked at as far as veterans eligible, we decided upon 2 park-and-place units. I'll just point you to the South Carolina star there. The Greenville C-Box sits between Anderson and Spartanburg, and so it's strategically located and will provide access to around 12,000 veterans who previously would have had to drive down to Columbia, which is in the center there, to try to get their lung cancer screening. The real neat solution is in Georgia, which will be parked in Western Georgia. You can see Atlanta is the hub there, and all of those little red dots that you see on the screen are different C-Box. And so the plan is to have this self-propelled mobile CT unit, which will offer not just lung cancer screening exams, but also other non-contrasted CT scans to at least 3 CBOCs in the area. That was delivered in January. And then in Alabama, you can see the red star in the top corner. Again, it was felt that the Park and Place unit was a better fit there. And so these are things that we're actively working on. Everybody likes to see the fun pictures. Up at the top is the purely mobile solution. At the bottom is the trailer that's parked at the Greenville CBOC in South Carolina. This is the one that a wrap soon to come, but on the inside, I thought it was really neat. You can see what the veterans see when they get scanned with the pictures there. So just to switch gears a little bit about how the VA is trying to move the needle and potentially impact the next iteration of the U.S. Preventative Services Task Force criteria. We talked a little bit about tobacco pack year history and how it's relatively simple. And that's what is the source of task force criteria. It's just age and smoking history. The problem with this, and what we know from lots of secondary data analyses and modeling studies, is that these types of criteria will miss some high-risk individuals, including Black people and women who are diagnosed with cancer at a younger age with lower pack year history. And cogent to the military population, those with other risk factors like occupational or military exposures that increase risk that we don't know how to account for. So too, those with a longer time since quit, past 15 years, also might be at high risk. And those that have a family history, et cetera. There's lots of different factors that go into an individual's risk for developing lung cancer. And interestingly, tobacco pack year history and age do not discriminate the spectrum of risk and benefit. And this is a study in the bottom right corner that I've been talking about for years now that took all of the National Lung Screening Trial participants and stratified them into risk based on a model from lowest to highest. And you can see the number of false positives and the number needed to screen to prevent one death from lung cancer was much higher in the lowest quintile of risk. Whereas the risk increases, you get a lower number needed to screen and less false positives. So too, cost is important and screening those at the lowest risk. And mind you, all of these patients that were looked at in this modeling exercise were screened in the National Lung Screening Trial. So risk varies. It varies between individuals, and it's a hard thing for us to predict. And so really that ties into the next piece, that providers really are not good at selecting patients for lung cancer screening who could benefit the most. And some studies that were done by some of my colleagues at the VA, both in Ann Arbor and at the San Francisco VA, showed that patients who stood more to gain for lung cancer screening were actually significantly less likely to be screened compared to lower risk individuals. And this included veterans with the highest lung cancer risk and Black people who are eligible for lung cancer screening. And so really this identifies a clinician need. They need better tools to identify which patients could benefit from the most from lung cancer screening. What we also know is that augmenting the current U.S. Preventative Services Task Force criteria with personalized prediction algorithms has a strong potential to improve lung cancer quality. In work done by one of my co-PIs, Tanner Caverly, we found that efficiency, effectiveness, and value is much better when you augment with personalized prediction. It helps to identify and prioritize lung cancer screening discussions for high benefit patients. It's very patient-centered. If you look at the CHEST lung cancer screening guidelines that Dr. Silvestri is an author on, they talk about tailored shared decision-making with personalized information. Equity is also a big thing. And in this paper that was published by Landy and colleagues, what you can see is that even with the change in the task force criteria in 2021 to reduce age and tobacco pack year history, there was still a disparity between whites and Blacks of the percent of potential gainable life years achieved. But if you add prediction, that approach effectively eliminates disparities by race and life years gained from lung cancer screening. So the right thing to do, but can it be done? And so we really want to be able to show, can this be done in real world practice? And in order to do that, the approach has to be acceptable to both veterans and busy clinicians. The process must fit seamlessly into clinical workflow, and the feasibility of doing so must be demonstrated. And if you look at the last task force guidelines, when they outline the future research and gaps, what they do say is that research is needed on the benefits and harms of using risk prediction models to select patients for lung screening, including whether risk prediction models present a barrier to wider implementation. These models are really great. If any of you have looked at them, oftentimes they require multiple inputs, and in the auspices of a busy primary care setting, do you really have time to input into the models? And so that's where the Prediction Augmented Screening Initiative comes in. This is a pragmatic observational trial that happens at the site level. We propose 2 interventions. One are primary care facing tools. So at the point of care, the calculations of risk and benefit will be done in the background, and it's presented in the currently used clinical reminder. So this is something that the providers are already using, and it's an additional highlighted sentence that indicates that someone's high benefit. And it will be also presented in a health maintenance tool that they use in their everyday practice. On the other side of the coin is the lung cancer screening coordinators. They're actively managing, as I talked about, shared decision-making visits, et cetera. And as more and more veterans are being referred, it's nice to potentially stratify those at the highest benefit. And so this dashboard that we've developed in beta test lists veterans at the highest benefit who have yet to be offered lung cancer screening. And the goal of this project is really to provide evidence that will show, yes, this is feasible to do, and it improves outcomes and reduces differences that were seen before. So in summary, we talked about lung cancer being the #1 cancer killer in veterans and screening having the potential to reduce this mortality. High quality screening is essential, and I would argue that the VA has organized a broad network and infrastructure to expand high quality screening with excellent clinical support, with training, standardization, platforms, adherence metrics, and an emphasis on tobacco treatment. Research that expands potentially the eligibility will increase access, helping us understand who will benefit the most and who may not benefit all. There continue to be challenges that remain both in VA and out of VA as it relates to lung cancer screening, including increased uptake, adherence, and incorporating tobacco treatment. And hopefully, as we work together across the VA network, both clinically and through the research enterprise, we will be the beacon to show others how it's done best and be able to provide the information and the results to show what can be done in the future, both in and out of VA.
Nicole, thank you very much. I guess I never mentioned this at the beginning of our talk, but 28 of my 31 years at the Medical University of South Carolina, I have worked at our Veterans Hospital, which is 2 blocks away, where Dr. Tanner currently works. And I have to say that, I've seen a lot in those 3 decades, and it's been incredible how much we've been able, through your work and others, improve screening and even general lung cancer care. And I think as I started my journey in academic medicine, most patients and providers were very nihilistic about lung cancer. There was this nihilism about, I did it to myself because I smoked. There was a nihilism about the treatment options. And there was no screening at the time. And right now is probably the most exciting time to be involved in this area, because we have both screening, which is one of the most profound ways to reduce lung cancer mortality, and better treatments. And the point of all of this is that the VA has taken both ends of that spectrum into account. They've really put a lot of effort into organizing lung cancer screening, but also a lot of effort into making sure patients get the appropriate treatment, even if they have an advanced cancer diagnosed. And so I want to thank you on behalf of all veterans for being a central part of that. Thank you again to PeerView and also our sponsors for this webinar. So thank you very much.